as I told some of you yesterday, there was a scientist called Raymond Alquist. He was the chairperson and chairman of the Department of Pharmacology where I did my PhD, and I was taught the cardiovascular system and the autonomic nervous system under supervision of the doctor who was supervised by them. يعني أنا حفيدته من العلمية هذا الدكتور. So why is this scientist important? I told half of you that he was the scientist who discovered that we have different kinds of adrenergic receptors. Before his discovery, and that was in the 40s, they thought that there were different neurotransmitters or hormones. One is responsible for stimulatory effects, such as the effects we talk about when we talk about the heart. So what kind of receptors do we have in the heart? The beta receptors, right? And when we activate them with epinephrine, what would happen? We'd have contraction. On the other hand, for example, the bronchi or the vascular smooth muscle cells, they have another kind of beta adrenergic receptor, and when they get activated, they cause relaxation and they inhibit the inhibitory pathway if we call it relaxation. So they thought there was something called, I forgot what they called it, like a sympathin, an activator, and a relaxin or an inhibitor. So he came up with the new idea that no, there aren't really two hormones or two transmitters. It's actually one, norepinephrine or epinephrine, but they modulate their work by working on different receptors. And these subsets of receptors, according to the organ where they are present, they modulate these differential actions. As I said, he tried to publish his work in the Journal of Pharmacology. It was rejected because it was opposed to everything that was known at the time. يعني زي لما اجوا يحكوا انه الارض كرويه كان يفكروها زمان مسطحه. Yes, what about helicobacter? Yes, yes. Oh, I didn't know about that. مين حكاك عنه؟ نحن نعرف القصة. الساينتست في كتير ساينتست زمان كانوا يعني ما كان الريسيرش they weren't as cautious as they were today. So somebody who wants to prove his idea, like this scientist who told, he would go and give himself the drug and show it in front of an audience in a conference. Is that what happened to this scientist?
He took the solution, Helicobacter, بعدين he took antibiotics to treat it and it resolved.
Okay. So I have a story, and maybe in a conservative community, but it's science. They were thinking, another issue ما إله علاقة بالcardiovascular system. They were thinking erectile dysfunction is a psychological issue. It's not a physiological problem. So one scientist in a conference, he proved it for them, where he injected himself with a drug and he showed that he can correct erectile dysfunction. So they were doing that. I don't know if somebody would do that today, but this guy, I told you, he tried to publish his work. It finally got published, and now it is the basis of our use of drugs, because now we have selective beta-adrenergic antagonists, we have alpha-1 selective antagonists, and these are the basis of the treatment of multiple cardiovascular problems. زي ما حكيت امبارح, he did not get the Nobel Prize, even though he deserved it. And this was because he wasn't really a very pleasant person. يعني ما كان عنده أصدقاء. You have to be very good in networking, to have multiple relationships, so people will nominate you. To be able to get an award, you have to be nominated. You cannot nominate yourself for most awards. And another thing, and maybe I would nominate him now, but you have to be alive to get the Nobel Prize. He did, though, get the best or the highest ranking prize in the United States called the Lasker Award. So حكيت take home message. نروح هلا نعزم بعض على قهوة to fix what we talked about yesterday, and to have good relationship, good personal interaction and teamwork once we start our work, even at now we can start. Now, what's the mechanism of action of these drugs? We're going to review again the autonomic nervous system. What kind of receptors are we talking about? We're talking about the beta adrenergic receptors. What are the beta adrenergic receptors we are interested in? Mainly the beta 1, because it's present in the heart. So how would this modulate the effect of these blockers on the heart? As you remember, beta 1 activation causes increased cyclic AMP, and we talked about myosin light chain kinase, phosphorylated myosin light chain, causing contraction. In addition to that, also it causes phosphorylation or activation of phosphokinase A, which phosphorylates calcium channel, leads to activation of those channels, entry of calcium to the cardiac myocytes, and thus we're going to have contraction. So if I block the beta adrenergic receptor, I'm going to block all these pathways. خليني أطفي ضوء لو واضحة السلايدات. No. Yeah, this is better. So beta adrenergic receptor coupled to GS protein form cyclic AMP, cause increase inotropy, inotropic agents. So the other thing, okay. Now we said we have different kind of receptors. We have the beta 2 adrenergic receptor. They're present in different sites. Among these sites, in vascular smooth muscle cells. In those vascular smooth muscle cells, they do not cause contraction. On the other hand, they cause relaxation. So as we said, because they are present in different organs, we have these differential effects. So how would this affect us? نرجع على الهارت. How would a beta blocker help us? احنا بنحكي عن heart, relieving contraction. How it can help us decrease the blood pressure? Decrease the cardiac output. So this is the main mechanism of how beta blockers work to decrease the blood pressure. Even though it is shown to be very good in lowering the blood pressure, and if we go back here, and we know that the beta 2 adrenergic receptor will cause relaxation. If we oppose it by a non-selective beta blocker, what will happen? We'll have constriction. That's why upon initial use of beta blockers, blocking this pathway will modestly cause an increase in the vessel tone or contraction, and initially it can cause an increase in the peripheral vascular resistance. Later on, this effect will be diminished, and the net or the major effect we will see that usually requires a couple of weeks to start through lowering the cardiac output. Now, what other organs have beta adrenergic receptors that will be related to the cardiovascular system? Kidneys, excellent. Lungs have them as well, but if we're talking about blood pressure control, we'll be more interested with the kidneys. So the kidneys have also the beta 1 adrenergic receptor, and upon its activation, it's gonna stimulate renin release. And you all know, but we're gonna talk about it again, a renin-angiotensin system. Renin will be converted to angiotensin 1, renin will convert angiotensinogen to angiotensin 1. Later it will be converted by ACE, angiotensin converting enzyme, to angiotensin 2. And angiotensin 2 will cause contraction of vascular smooth muscle cells, leading to vasoconstriction and elevation of the blood pressure. In addition to that, angiotensin 2 have effect on aldosterone. We talked about these in physiology. And this will cause increase in the reabsorption of sodium and water, increasing the volume, increasing tonicity of the blood vessel by higher concentration of sodium, leading to elevation of blood pressure. So when we block the beta 1 adrenergic receptor in the kidney arteriole, it will block all of these pathways also we've been talking about. That's why a beta blocker will also block beta 1 adrenergic receptor in the kidney, which will decrease renin production and decrease vessel tone. So going back to propranolol. Propranolol, as you all remember, we know it by heart now, is a non-selective competitive antagonist of both beta 1 and beta 2 adrenergic receptor. What are its cardioprotective effects? حكينا رح يقلل الactivation رح يمنع norepinephrine to bind to the heart. So we have decreased in the heart rate, decreased contractile force, decreased cardiac output. It causes delay in the AV conduction. And another additive thing we said, we can use it to neutralize reflex tachycardia that is induced by vasodilators. Other effects, other than its effects on the heart, it reduces central sympathetic nervous system activation, because if you remember from last year's lecture, it is lipid soluble, so it's going to cross to the blood-brain barrier, and this explains some of the side effects. What side effects?
Nightmare.
It causes nightmares and depression. Excellent. Now, other side effects, and we all know we're going to talk about a drug that's going to decrease the cardiac output, it's going to lower the blood pressure, so we would expect that we will have hypotension. We're going to have AV block, but hypotension to less degree than other vasodilators. AV block, severe bradycardia, negative chronotropic effect. We said possibly heart failure is going to lower the work of the heart, so we use it again in heart failure, but in certain conditions of heart failure, when we have compensated heart failure, we stop using it when we move from compensated heart failure to decompensated heart failure. With congestive heart failure, some people indicate they've been seen benefit, but again, it depends on the patient's condition and what's the ejection fraction. The rationale for use of beta blocker in heart failure will be explained in the heart failure lecture probably next week, or maybe the last lecture this week. Side effects, bronchial constriction and spasm. So we do not use a non-selective beta blocker in asthmatic patients or patients with COPD. Again, we talked about acute withdrawal syndrome, and this means that we should never abruptly stop this medication. We should advise the patient never to abruptly stop this medication, especially when I have a patient who have heart condition, who have history of ischemic heart disease, because this predisposes to a infarction, a heart attack, angina attack, or can predispose for an arrhythmia if I have a patient who have been taking drugs that can modulate ion channels or antiarrhythmic agents. Do you remember again what's the mechanism of, yes. What's the mechanism of acute withdrawal syndrome? Increasing the sensitivity or the number of receptors. And this is what we talked about with dynamics. I want to make sure everybody's on the same pace with me. We said whenever I have continuous use of an antagonist, the body does not like that, so it tries to compensate or bring back the level back to normal, so it increases the number of receptors or increases the sensitivity of the receptor. And actually we can increase the sensitivity of the signaling mechanisms in the cell. But all of that will lead to increased sensitivity in general to that original ligand. We said once a patient decides, or a physician, to suddenly stop this medication with a higher number of receptors, a lot of adrenaline, noradrenaline circulating in our body, this will be able to activate the heart above normal level, which can predispose to a ischemic event or myocardial ischemia or an arrhythmia. مين بده يصحى من النوم هلا؟ بس
مش المفروض العكس، لو زاد الريسبتورز بيصير الكمية قليلة باعتماد
more possibilities.
هلا كل ما يعني احنا الدراج دائما موجود, the drug or the ligand is present in abundance in much higher concentration than the amount of receptors. هلا yes, we know about spare receptor, we don't utilize all the receptor, but it's a percentage. With more number of receptors, there is more chance of activation, so more of an effect we're going to see. Other side effects, very important side effects. It can cause increase in triglyceride levels, decrease HDL levels. So we have to be careful in patients who have lipid abnormalities. In diabetic patients, we have two important considerations. It induces glucose intolerance, so we have to be careful in diabetic patients and obese patients. Another thing it does in diabetic patients, it masks the symptoms of hypoglycemia. What do I mean by that? So once a diabetic patient have low sugar, it's going to manifest. There are going to be a lot alarming sign for him to go and seek sugar because he's gonna faint. So what happens? He have increased heart rate, he has sweating. Now, because beta blockers are going to block the sympathetic nervous system activation on the heart, we're going to have decrease of these alarming symptoms for the patient, so he can collapse or faint because of hypoglycemia without having this alarming sign. So we have to warn our patients if they are diabetic and taking a beta blocker that they should watch out for their sugar levels more often, let's say. Yes. هايبو نقص يعني. Yes, hyper. هلا احنا بنحكي عن مرضى we're talking about a diabetic patient who is, for example, on insulin or an oral hypoglycemic, so he is taking a medication. Sometimes if you take your medication and you do not eat, you're going to have a lower level of sugar than you need to, because you did not eat enough to counteract that effect of the medication. And it happens a lot. Or if they leave themselves without food for hours, they will have hypoglycemia. And this is one of the most common side effects associated with oral hypoglycemics or insulin. You've learned about that with endocrine system, right? We talked about the CNS side effects. It causes BBB. It causes nightmares and depression because it crosses the blood-brain barrier. Another indication one of your colleagues in the other section told me or reminded me of something we talked about, not related to a cardiovascular disease but related to the heart. We use it for stage fright. We said, if I have a patient, a person who's about to perform in front of an audience and he is apprehended or anxious, this will result in increase in the sympathetic activity, which will gonna cause increased heart rate, a lot of effects of activation of sympathetic nervous system. So in order for him to relax or have less of a heart rate, we give him a beta blocker. So one other indication for it, not related to the cardiovascular system, اللي هو stage fright أو بنسميها performance anxiety. We talked about the contraindication. It can cause bronchial asthma. It is contraindicated in bronchial asthma because it causes constriction. And this is mainly for propranolol or a non-selective beta blocker. It can cause peripheral vascular disease. It's contraindicated in peripheral vascular disease. Because, especially the non-selective, because of its effect on the beta-2 receptor in the vascular smooth muscles. Yes. هلا هو بالنسبة لسؤالك, your colleague is asking about high renin and low renin. That's why people with high renin hypertension, we recommend for them to use beta blocker. كمل الشق الثاني من سؤالك. Yeah. ما بيصير dehydration, but we don't recommend it to use it for low renin hypertension. So one of it's indication for patients who have high renin. Who are the people who have high renin hypertension? Wide, high renin, wide and young. With low renin, elderly and Africans. Okay. Because it can initially, in the first period, cause increase in the peripheral vascular resistance, the vasoconstriction. Okay. What are the beta blockers available in the market? There are so many. We're just giving some names here. I'm not going to ask you about major differences. يعني في examples هون atenolol, metoprolol, nadolol. I just want to focus in this part of the course about the basic knowledge of the general group, few examples of them, and if there is special characteristic of one subset of these drugs, we're going to focus on it. Now, when do we use beta blocker? We use it for mild and moderate hypertension. We said yes, one indication for its use is patients receiving vasodilators, and this is mainly to prevent reflex tachycardia associated with the use of vasodilators. In addition to that, they're useful in controlling blood pressure in patients with underlying heart disease, يعني patients who have heart failure who are taking beta blockers for heart failure. If they have hypertension, I'm gonna be targeting two conditions with one drug, so that would be beneficial for me. Yes.
في واحد من الدراجز كان مثلا مكتوب يوسفول كأنه يعني
اللي هو it's selective, yeah, because it is selective. تنين حيكونوا useful. So atenolol, metoprolol, both are selective for beta 1. Because why would we worry about asthmatic patient? Because beta 2 is present in the in the smooth muscles of the bronchi, and upon its activation, there's a relaxation. Upon its blocking, so let's again remember the autonomy. Beta 1 is present in the heart. When it gets activated, it's going to cause contraction of the vascular of the cardiac muscles. Okay, ما أحكي بسرعة عشان ما أغلط. Beta 1 heart, cardiac myocyte contraction. Beta 2, one of the sites is present in other sites. Bronchi, we have smooth muscles of the bronchi. It causes relaxation when they're activated with the sympathetic nervous system. If I block it with a non-selective blocker, it's going to cause constriction. That's why we don't recommend to use a non-selective blocker in asthmatic patients. Selective blockers will only work on the heart, hopefully, but they actually are not that pure, but they will have less effects on other subsets of receptors. So they are preferable to be used in asthmatic patients.
حتى مع الأوفردوز.
No, with overdose we said we lose selectivity. ممكن with even a non-selective drug you will see some degree of constriction يعني بس. Yes, but why would they prescribe more of nadolol? يعني it's an option. We use propranolol a lot. يعني it's an option. It depends على what's available. يعني it depends what's available. Yes, I mean, it's an option. It's working, but as a non-selective. يعني هلا احنا ما اتوقع هو ارخص. No, it's one of the newer drugs. But شو نفعته? They made it. They found it. They tried. Maybe if you look up papers, how do we decide what to use? We have all of these names.
Guidelines.
We have guidelines, right? But in the guidelines, you're also going to find this or this. It depends on the patient. Depends on price. So a lot of things govern that. How do we decide? ACE. رح نحكي عنهم هلا. Yes. Versus ARB اللي هم they are هلا mainstream treatment for hypertension are either angiotensin converting enzyme inhibitor or angiotensin receptor blockers. Both of them are equally effective in lowering blood pressure. How do I determine? A lot of studies. So whenever a new drug is produced or introduced to the market, people go and do studies. Which is better, nifedipine or amlodipine? What is the advantage of using amlodipine over nifedipine, for example? So they do studies. Sometimes they found some advantages, sometimes they don't. But we have that drug. It is available. Maybe some studies will show it have a benefit in certain condition, or it have, for example, another effect we can utilize, or sometimes it have a side effect that makes it not very suitable for a particular patient. Yes, we finished this slide. So let's move on to talk about a new group of drugs that are related to the renin-angiotensin-aldosterone system. اللي هم the first group of drugs we're going to talk about هم angiotensin converting enzyme inhibitors. How they were discovered, there were workers or mal in farms of bananas in Brazil. When they were bitten by a specific snake or a viper, they would collapse. What do I mean by collapse? Collapse means they have hypertension and they will fall or have faint. So one biochemist, and of course these patients will be moved to the hospital. So he noted that a lot of those workers that were bitten by this specific viper or snake have this effect. So he wanted to study the venom. It's no venom. Venom. Okay. Venom is the bad guy باتمان سبايدر مان هي عشان هيك تصير كلمة غريبة